I'm Hany Elmariah. I'm an assistant member at the Moffitt Cancer Center, Department of Bone Marrow Transplant and Cellular Immunotherapy. I'm here at the TCT TANDEM conference in Orlando, Florida, presenting the study, which is a collaboration between Moffitt and the City of Hope, looking at the effect of mycophenolate mofetil dose per kilogram on clinical outcomes in allogeneic transplant for patients getting post-transplant cyclophosphamide for GVHD prophylaxis. So historically, haploidentical transplant with post-transplant cyclophosphamide has been sort of the standard approach to doing haploidentical transplants over the last 10 years or so, or more actually. And now post-transplant cyclophosphamide is also emerging as a standard treatment for graft versus host prevention in the setting of matched donor transplants. And as originally the protocol was developed, it combines post-transplant cyclophosphamide, mycophenolate mofetil or MMF, and tacrolimus. And the MMF is dosed as 15 milligrams per kilogram based on the patient's weight, but then there is a cap of 3 grams per patient per day. So when patients exceed 67 kilograms, they get a lower relative dose of the drug. So we wanted to look, as patients go over that weight, compare the relative dose exposure based on their body mass and see of MMF and see if that impacted their clinical outcomes. So this was a retrospective study, again combined between Moffitt and City of Hope. We looked at patients divided into different quartile groups of body mass and MMF exposure, less than 29, 29 to 34, 35 to 41, or greater than 41 milligrams per kilogram per day. And going through, ultimately the conclusion was that the dose exposure did not impact clinical outcomes. And specifically, the ones that we had hypothesized might matter was neutrophil engraftment. And as shown in this figure, there was no difference in neutrophil engraftment. Also, since this is an immune suppressant, we thought that the different exposure to MMF might actually affect the rates of acute graft versus host disease, but in this cohort, there was no difference in acute graft versus host disease based on the different dose exposures. Looking at relapse, also there was no significant difference, although there was a trend towards a higher exposure to MMF causing a higher rate of relapse, although that was not, again, statistically significant. So that's something that could be explored maybe with larger studies in the future. But ultimately what we found is that the MMF dose does not seem to impact outcomes very much, which tells us that perhaps this is part of the regimen that could be changed or altered or maybe replaced by something else that could more significantly improve clinical outcomes without causing immune suppression and the same rate of infection or complications that MMF can.